So first and foremost, thank you guys so much for joining us today for the third in our webinar series for Stroke in May. My name is Danielle Harmon, and I'll be your moderator today. And our experts are going to talk a little bit today about stroke care from the very first signs of a stroke through stroke recovery and stroke treatment in that process. So first and foremost, let me tell you a little bit about ARH if you're not familiar. Appalachian Regional Healthcare is a nonprofit healthcare system operating 11 hospitals in Kentucky and 2 in West Virginia. We are the largest provider of care and the single largest employer in Southeastern Kentucky and the third largest private employer in West Virginia, Southern West Virginia. We operate multi-specialty physician practices, home health services, home medical supply stores, physical, occupational, and speech therapy, and retail pharmacies. Our mission is to improve the health and wellness of Appalachians, which is why we have this webinar series and all of our other community events that are like it. So we try to fulfill that mission. Some housekeeping items just before we get started. And this is something we always say on all of our webinars. The Q&A will be open and the chat box will be open throughout this webinar and this panel. So please feel free in asking questions, feel comfortable, and we'll try to get those questions answered for you. If you have asked questions via email beforehand, I have those in front of me, and then I'll give those to our panelists and kind of call them out throughout our webinar so they can answer those questions. Our experts, as usual, cannot answer specific medical advice or referrals. So if you need a referral or if you have questions about your own personal health, then we ask you to please contact your primary care provider or your other healthcare professional. And if you do not have one, then we have a listing at arh.org of our professionals that should be able to help you and our providers. Today, we have an amazing array of experts that I'm really excited about to talk to you about stroke care. In lieu of me taking forever, as I usually do, to go through bios, I hoped that each of you would kind of introduce yourselves and tell us where you work and how you work in stroke care. And if it's okay, I'd like to start with Abby. Abby, do you mind?
Hello, thank you so much for having me. My name is Abby Leckler, and I am from the American Heart, American Stroke Association. I am a quality improvement manager, which means that I get to work with healthcare agencies and pre-hospital providers throughout a multi-state region, making sure that they are treating stroke patients the way science and guidelines suggest that they should. So I have the pleasure of working with ARH hospitals in Kentucky as they implement our guidelines and care for stroke patients.
Thank you so much. Robin, would you like to go next?
My name is Robin Tuttle. I'm a registered nurse at Middlesboro ARH. I'm the house nurse coordinator by day and a stroke coordinator. I've been a nurse for 28 years and I've been with ARH for almost 15 years. And I've been fortunate to be with them on their journey for an acute stroke ready hospital. So know a lot about stroke right now.
Good, thank you. Thank you for being here. Justin?
My name is Justin Cantor. I'm a nurse practitioner. I've been in neurology about 10 years, been a nurse practitioner in neurology for the last 5 years. So I do both inpatient and outpatient care via telehealth. So we see patients via the camera at all of the ARH sites and also see them at home. So.
Perfect. Thank you. And Dr. Corey.
Hey, George Curry, neurologist. Been with ARH for about 8 or 9 months officially. And sort of challenged with building out a comprehensive or collaborating and building out a comprehensive neuroscience service line, which many of you already know about or have heard about or have been a patient or are familiar with. Came from Charleston, South Carolina, where I trained for a number of years in a really large academic setting there, and then have worked up and down the East Coast at about 15 different hospitals since then to kind of hopefully use that knowledge and continue off the progress we've already made to really quickly and successfully elevate stroke care and general comprehensive neuro care across the region here.
Perfect. Thank you, Dr. Corey. We really appreciate you and are so happy to have you on our team. So I think the very first thing we should do is probably start at the beginning. I think that'd be most beneficial. So let's talk about what is a stroke and what does that mean? I know there are a couple of different types of stroke. Justin, do you care to take that question?
Sure. So I always tell people that stroke, think of it like a pipe problem in your house. So you have blood vessels in your head. just like you have blood vessels everywhere, we just like to think of them as pipes, right? So there's two types of strokes. There's a stroke caused by a clotting problem or a clogged pipe, or there's strokes caused by a burst blood vessel or a burst pipe. So the first type of stroke, which is the most common, is an ischemic or a clotting stroke. What happens is, due to a number of reasons, an artery can become blocked. An artery is the part of the body that takes blood to a certain part. So that artery becomes blocked. When it becomes blocked, no blood is able to get through. Blood is what supplies nutrients, oxygen to the tissue, and brain tissue dies. So that's what results in the stroke, is the death of the brain tissue. We'll get into treatment of that a little bit later on, and prevention as well. The second type of stroke is called a hemorrhagic stroke or a bleeding stroke. Think of that as a burst pipe. Typically what happens is the pipe bursts, you have blood that leaks out. That blood can compress the surrounding tissue, causing cell death, which causes you to have weakness, numbness, etc. It's treated totally different, and we'll get into that a little bit later on as well.
Perfect. Thank you so much. I love the way that you explained that. I needed that. So Abby, working for the American Heart Association, I'm sure you have access to all of this data about stroke in Appalachia. So can you talk to us a little bit about, the prevalence in our service area, which is Kentucky and West Virginia, and the stroke belt?
Absolutely. So stroke is the number 5 cause of death in the United States, as well as both Kentucky and West Virginia. We have moved down a little bit over the past couple of years, which is great, great work for all of us. But it's also the number 1 cause of disability, which a lot of people don't know or really think about. And I think sometimes that's just as important as cause of death. You mentioned the stroke belt. So Kentucky is part of the stroke belt. West Virginia is not. And the stroke belt is a group of 11 states that are known to have a higher prevalence of stroke. It's been estimated about 35% higher than anywhere else in the country. And that could be due to some of the risk factors for stroke that are also maybe a little bit higher in those states, including smoking, high blood pressure, high cholesterol, obesity. But what that really just means for the folks watching at home is you just really need to take care of your health, make sure that you know what your risk factors for stroke are. If you do have high blood pressure, high cholesterol, that you're making sure that you're speaking with your provider and just managing that risk so that you don't end up in the hospital with a stroke.
Thank you so much. Let's go to Robin. So in your job as a stroke coordinator, I know that you spend a lot of your time educating the community about the signs of stroke and how to recognize that. So what are the signs to look for, and how do you know if you're having a stroke?
Well, here at Middlesboro Hospital and all the ARHs, we have a mnemonic, and it's called Be Fast. We teach that to every employee in the hospital. So when we go out into the community and teach the Be Fast mnemonic, we also teach that to them also. And when you think of Be Fast, you just look at the initials and B. Are you having trouble with your balance, sudden loss of balance? E, are their eyes had sudden loss of vision, one or both eyes? Is their face drooping? You might want to ask them to smile. Is their arms weak? One or both arms could be weak, but normally it's on one side of the arm. That's your F. And then A is your arm weakness, and then speech difficulties, like I'm having now. And then you can ask them to repeat a simple sentence, something that you know that they know how to say. And if you notice that that's something that's different from them, that there's a change, then the T stands for time. And it's time to call 911. We want you to get to the hospital as quickly as possible. And the first important question they're going to ask you is, when did this begin? So last known well. So let them know that too when you get there.
Thank you. So speaking of time, that's very, very important, as we know, for our stroke outcomes and how different they can be depending on how quickly that you get to the ER. So Abby, do you mind talking about how or why that's so important to get to the ER pretty quickly?
Absolutely. So you may have heard the phrase time is brain, and that's super important because every second of a stroke, 32,000 brain cells die. So think of how quickly those seconds tick by. That's why we urge you, as soon as you recognize these signs or symptoms on yourself or a loved one, please call 911 immediately. Quickly diagnosing the type and location of the stroke can help prevent death and permanent disability, which we talked about earlier. And many of the treatments for stroke are time sensitive and time dependent. And so that's why the information that Robin shared about, what time did these stroke symptoms start is so important, because that's how we then identify potentially what treatment you may be eligible for. And finally, calling 911. So the T in FAST, be fast, is time to call 911. And we know that activating EMS will get you to the hospital quicker. And another great thing about using EMS is that they are then eligible or able to call the hospital ahead of time and let them know that they're bringing a stroke patient, which allows the hospital team to do everything that they need to do behind the scenes and get ready for your arrival.
Perfect, thank you. So speaking about the ER, Robin, would you mind telling us what happens, if we think we're having a stroke, we make it into the ER, what happens when we actually get there? What happens next?
So she mentioned, if you come by EMS, they radio in and let us know. At that point, or if you come by car and we go out to your car to bring you in, we know what's going on. And as we come in, we'll announce, that there's a stroke alert. Immediately, you're brought into the emergency room. A nurse and a doctor will talk to you real quickly, and then we're going to take you straight to radiology. At that point, we're going to do a CT scan, and this is going to let the medical team make a diagnosis. We're going to look for bleeding and any other abnormalities. For most new ischemic strokes, you might not see any abnormalities immediately because the blockage hasn't had time to start. However, we will see the ER doctor upon arrival, and then possibly you'll be seeing our neurologist also. We also use the telestroke. That's been started in the last couple of months. Each community has one, and those physicians will be asking you a lot of questions. Last known well is the most important one. We're going to be asking you about your symptoms and when they started. While you're in CT, we'll be checking your finger stick glucose. We'll be asking you all those questions. And then when the physician comes on, we'll determine if you need another procedure. It's called a CTA. And they use an IV dye, and they'll give you that. That way it can light up and we can see exactly maybe where the blockage is, like Justin was talking about. And while this is going on, the team is going to be checking your blood pressure and asking you all kinds of questions. And all this will happen within immediately upon arrival in the emergency room.
So just as quickly as possible.
Yes, absolutely.
Perfect. So Dr. Corey, let's keep moving through the continuum of care. So if someone comes into our emergency department and they are diagnosed with having a stroke, what happens after that? What happens as far as stroke treatment moving forward?
That's a good question. It's a pretty variable question depending on what type of stroke is Justin referenced. If it's a bleeding stroke, you're going down one pathway. There's a big fork in the road that happens after CT, and it's bleeding strokes and everything else is how we look at it. Bleeding strokes are almost kind of the opposite of a clotting stroke, if you will, because you don't want to use blood thinners because you're actively bleeding. And so we'll usually try to decrease blood pressure quickly for those bleeding strokes. We will reverse blood thinners potentially. And in the modern era at ARH, we will usually helicopter patients to the UK where they have neurosurgery actively, which, hopefully we eventually get to that point here in Eastern Kentucky too. When the more common statistical pathway is clotting strokes. So they're just more often seen. So fortunately, bleeding strokes are a little more dangerous and they're less common, which is in a way good. The clotting strokes are when we start to think about the blood thinners. And if you show up fast enough, which is the very, very important part of stroke, if nothing comes across in the message today, it is that the one thing I would take from this, from a patient standpoint, is time. And of course, recognizing strokes is important, but any neurological abnormalities, speech, all the things we talked about, weakness, anything pops up that catches you off guard, we would try to favor safety. Just call 911. We'll sort it out in the ER. And time is really, really, really important, because if you show up within 4.5 hours, I can use a blood thinner potentially if it's not a bleeding stroke. That's a very valuable tool. It's something that's been validated for the last 20 or 25 years. We've got thousands and thousands of patients that the AHA representative can validate it over many, many, many studies called TPA. And you'll see me consenting you and talking about bleeding risks and other things. But that medicine can only be used if you show up within 4.5 hours from when that symptom started. So unfortunately, a lot of patients across the country, my experience, they will say, well, you know, I'm not sure if this weakness is going to go away on its own, or maybe this is just I slept on my arm wrong, or, you know, maybe this is something else going on. Let me go back to sleep and nap it off or whatever and see if it goes away. And unfortunately, when it gets worse, they come in and I can't do anything with the blood thinners because they just kind of waited. One other thing that I would think about when the symptoms start, not only call 911 fast as you can, don't wait, but also I wouldn't recommend taking aspirin at home. So that's something that I see, interestingly, I don't hear a lot talked about in educational series, but everyone seems to want to think naturally, because when they have chest pain, they take aspirin, that when I start having neurological deficits, I should just pop, you know, 4 or 5 aspirin, which is very commonly done. And you can imagine if it's a bleeding stroke and you take an aspirin like that, it can be devastating. So until we have the CT scan and you show up at the ER, I would not recommend just arbitrarily saying, I have stroke symptoms, let me take aspirin. But that is almost across the board done by most patients, and it can be dangerous. So once we make the decision on a blood thinner and we get the CT scans, we would then say yay or nay on the blood thinner, and then we would make a decision whether or not you have a big blockage or not as to the next levels of care. Sometimes the really big blockages we send over to UK because we don't have neurosurgery yet. But if it's not a big blockage, you know, the good part is with all this neuroscience stuff we're doing, you can most likely, you can stay at your facilities locally in the community, which I think is a very, very valuable resource to offering telehealth and the things that we're doing. Is if you don't have to travel 2 hours, that's a great, great thing for all the patients across the community. And that's kind of what we're trying to do.
Thank you. So, you know, moving forward, we're going to keep continuing on that continuum of care I was just talking about. So what happens if they're admitted after a stroke? Justin, would you like to take this one?
Yeah, sure. So the most important thing about coming into the hospital is figuring out what caused the stroke so we can figure out what's the best way to prevent you from having another one. So you're going to go through a series of tests. So the first test you get, like Dr. Corey was saying, is as soon as you hit that ER door, bam, you're getting a CT of your head. That will help us determine bleeding versus clotting stroke. So for the purpose of this lecture, we're just going to talk about what will happen when you have clotting stroke. So we're going to look at a couple things. So the first thing is we're going to look at your blood vessels. Depending on the kind of stroke symptoms you've had will kind of depend on how we look at your blood vessels. There's a few ways we can do that. We can do it with an ultrasound, so looking at the blood vessels in your neck. We can also do it with a CT scan with some dye like they were talking about earlier, or also an MRI scan to look at the blood vessels in your head and neck. That will help us get a good indication of, was this stroke caused by a clotting problem in a big blood vessel, or was it caused by a clotting problem in a smaller blood vessel? Normally, we're not able to see that on a blood vessel study, but that's where the next test comes in. So we're going to get an MRI of your brain if it's possible. MRI is a great picture. I always tell people a CT scan is like looking at your brain on a black and white TV. It's good at looking at blood. It's good at looking at big stuff. But like we talked about earlier, stroke may not show up on that scan for 24 to 48 hours. And if it's small, it may not show up at all. MRI scan will tell us if you have ever had a stroke. Your MRI will turn positive in 5 to 10 minutes from the time your symptoms start. So we can tell, is this stroke super new? Is it a couple days old? How big it is, where it is, depending on what it looks like, what might have caused it, and what we can do to prevent it from happening again. The other test everybody should get is an echocardiogram, which is an ultrasound of your heart. So we're going to be looking at a few things. One, we're going to be making sure that the pump is pumping enough blood. We want to make sure that it looks like the pump is emptying fully. Also, we're going to look at the top part of your heart, particularly sometimes we'll see patients who have what's called atrial fibrillation, which is another common cause of stroke. And we can get some good indications on that echocardiogram if you might have that. Assuming you don't, usually the standard of treatment is simple. It's aspirin. Aspirin is a simple medicine, but it's one of the best medicines we have to prevent stroke. Recently, we've started using a combination of aspirin and Plavix. Plavix is a medicine similar to aspirin, but it's a prescription medicine for 21 days. And then after that, we go back to just aspirin or Plavix, depending on your circumstances. The other medicine we often use is a cholesterol medicine. So statins in particular. They have been shown over many years to help prevent the risk of stroke. They can help stabilize any blockages that you may have in your blood vessels and prevent them from getting any bigger. If your stroke is found to be due to atrial fibrillation, like we talked about earlier, you may be a candidate for a stronger blood thinner that you would be on for a long time. But that's something that we would talk about if that meets your individual need. The other thing is, normally when you come to the hospital, people are very concerned about their blood pressure. Say, I'm having a stroke. I want my blood pressure down because I heard high blood pressure can cause a stroke, which is true in the long term. But in the short term, we're going to have your blood pressure really high. So you might see numbers as high as 220 over 110, and we may not give you blood pressure medication. That is short-lived, but the idea is that your body naturally pumps your blood pressure up as high as it can to get as much blood flow to that area of the brain as possible. We used to knock people's blood pressure down immediately after this and found that people actually do worse if we do that. But usually after about 24 hours, then we'll gradually bring your blood pressure back down to a safe level. As far as next steps after the diagnosis and treatment is outlined, you're going to see physical therapy, occupational therapy. Physical therapy is more of the big walking strength stuff. Occupational therapy is more of the daily needs, so helping to eat, helping to dress, helping to bathe, those kind of things. And then you'll also see speech therapy if necessary, and they'll help work with swallowing and speech difficulties that are often seen with stroke. You'll see us, you will see a lot of nurses, you will see likely home health people, and you will be getting a lot of education. Depending on how bad your stroke is, you may need to go to rehab for a short period of time or a long period of time, or home with home health, or even home with nothing. It just kind of depends. But the big key is that you keep follow up. So just because you saw us in the hospital doesn't mean we're done. We need to see you in close follow up, make sure you're tolerating your treatment, make sure that you haven't had any recurrent symptoms, and just overall get you as strong as you can.
Thank you so much, Justin. So I think my next question should probably be for Robin. So we talked a little bit about if your symptoms go away, and I think this was Dr. Corey mentioned it earlier, and we have a lot of people that would just, go back to sleep or feel like, well, that weakness kind of went away, so it must not have been what it was. Can you talk a little bit about what to do if your symptoms go away and if they still need to come to the hospital? Again, this is probably a reiteration, but please go ahead.
TIA.
Sorry.
TIA is what we're talking about. It's actually a temporary blockage. It doesn't usually cause any permanent damage, but it's commonly referred to as a warning sign. It's something that you want to be looking out for. So if you do have those sudden onset of one-sided weakness and then it goes away right away, the answer to that question is probably you need to go to the emergency room to make sure it's okay. It could be, like I said, a warning sign that something bigger may be on the horizon that's going on, and let us check you out and make sure everything's going to be okay.
I want to add a little piece of that if it's okay. So the interesting thing that we see when we see lots and lots of volumes of strokes across many, many states and regions is you start to notice trends in this quote unquote TIA. And a lot of things can sound like a TIA, and that kind of goes into, I was confused for a minute, or my arm went weak, or, I fell and I kind of lost consciousness. I'm not sure if I should go in. In general, I would always say favor caution when it comes to neurological problems and cardiac too. And that means, again, just because it went away, just because, you feel back to normal in a short amount of time or hours later, absolutely come to the ER, because even as neurologists, when we see the patients and they give us a story, we get fooled sometimes. And what I would also say is that a TIA, or a transient neurological deficit, some people call it a mini stroke, which is kind of a misnomer, but those symptoms, we find in about a third of those patients, they actually had a stroke and their symptoms went away. And only when we get the MRI do we realize it was positive. But because the stroke was so small, they came back to normal. You really want to know if that was a stroke, because how we prevent a really big one from happening is relying on us seeing you and you come into the ER and us realizing you actually had a stroke. So that's a really good thing that people don't realize is, well, I had a TIA, it's a TIA. But a large portion of those TIAs or symptoms that went away are really a stroke. And that is really dangerous because you might have, like Justin said, atrial fibrillation, and we're not going to go looking for it if you never showed up and we didn't catch the stroke on the MRI. So really important that anything neurological, you got to come to the ER or it can be very dangerous in the future.
Seek care as soon as possible. So Dr. Corey, I know you just spoke, but I'm going to ask you to speak again. So the treatment of bleeding strokes, I know we talked about that a little bit in the beginning, but can you talk a little bit more about the treatment of that type of stroke versus the other and what that means in our hospitals?
So fortunately, bleeding strokes, we get, depending on the data you look at, it's about 20%, and clotting strokes are about 80% of stroke. So bleeding strokes, that kind of fork in the road of stroke types, they can look very similar to any, the clotting strokes. You can't tell the difference. That's again why it's important to call 911 quickly and don't take an aspirin or a blood thinner just because you think you're having a stroke, because you have no way of knowing if it's a bleeding stroke, which you just, that causes more harm if you take blood thinners for that. So the first thing we do is we get the CT, and every type of stroke we see, is it a bleeding stroke or a non-bleeding stroke? And if it's a bleeding stroke, we generally drop blood pressure because, as Justin said, you basically have a hole in the pipe being your artery, and it's gushing blood into an area it shouldn't be gushing into. And so we'll drop the blood pressure. It's just like a pipe in your wall when it bursts. You don't want a lot of pressure because that means more fluid, or in this case, blood, is gushing into where it shouldn't be, and it's causing more problems and more injury. So we'll drop your blood pressure down. And if you're on blood thinners, depending on what those blood thinners are, especially blood thinners for atrial fibrillation that are a little more potent than aspirin, we'll reverse those usually. And at the current time, when you show up at our facilities and we see you with these types of symptoms of bleeding stroke, we would then transfer you to a high level of care, which typically would be University of Kentucky at this point. You would then be admitted to the neuroscience ICU, which is kind of a higher level of care neurology ICU dedicated with neurosurgeons and neurointensivists, which is a fellowship training specific for high level strokes and bleeding strokes. And they would kind of monitor with repeated scans and MRIs and kind of just track and trend, and hopefully the bleeding stops with all the measures above. But in certain circumstances, they have to intervene with, certain surgical interventions. The ticket, thinking from a patient standpoint, I want to just make these little plugs that are non-academic, non-heavy clinical plugs that I think are high value from this conference. And one is call quickly, no matter anything neurological, call 911. Two is don't take blood thinners just because you think you're having a stroke. And three is blood pressure, blood pressure, blood pressure. Whether you're having a super high blood pressure that causes the pipe to burst and causes the bleeding stroke, so you don't want it for that reason, it causes heart attacks. But long term, we found that the highest associated, or what we call the most linear associated risk factor of cholesterol and diabetes and high blood pressure and all these things you hear about, the one that we say that if it's elevated, your stroke risk linearly goes up, is blood pressure. And almost all the strokes that are non-AFib strokes, the most common stroke called a lacuna or a small stroke, is almost always associated, we see hypertensive patients. So not only are there really bleeding strokes from dangerously high blood pressures caused by blood pressure problems, but the most common risk factor we see from clotting strokes also is actually blood pressure. And that doesn't mean that, I commonly hear with all patients, including myself, doctors are the worst patients in general. Essentially, we always hear, well, I see a patient, their blood pressure is 180 over, 100, and it's really high. That's very elevated. And they say, well, when I go to my doctor, I check it once every 3 to 6 months, and it's always normal. And we're seeing it, and they're having a stroke, which indicates that it wasn't probably usually normal. And what we usually find is that you need to, if you're a hypertensive patient, which many people, including myself, are hypertensive, it comes with aging and lifestyle and other things. It's good that you check your blood pressure relatively often, because if you're not checking it, I would say seeing your doctor once every 3 months or 6 months is not enough data to really see if it's actually usually elevated. It's out of sight, out of mind. You're not going to necessarily know if your blood pressure is high, but it's really important that you maybe go to CVS and get one of the $25 blood pressure cuffs, or, you know, there are many programs that will donate them. It's important to get as much blood pressure data as you can, because it's a very dangerous thing for not only stroke, but also cardiac risk factors.
Thank you, Dr. Corey, which is why they call it the silent killer, right?
There you go.
Got to pay attention. So let's go now to Abby. So Abby, can you talk a little bit about, as I mentioned before with AHA, you have this data, who is most at risk for stroke? Or are there people that are at more risk than others? And then after that, maybe what are your ways that you can reduce your chances?
Absolutely. So you've probably heard, we've talked a lot about the risk factors of stroke throughout this call today. So having high blood pressure, high cholesterol, having diabetes can all put you at an increased risk. In addition, some of those lifestyle factors, including cigarette smoking, a diet high in fat, lack of regular exercise, those can all contribute as well. So anyone with those risk factors should definitely make sure that they are working with a healthcare professional to make sure that those are managed. You've also heard about atrial fibrillation, which is an irregular heartbeat and has an associated higher risk of stroke as well. But in addition to some of those risk factors that can impact any individual, there are also certain groups of people who can be at elevated risk. You may have heard that African Americans can be at higher risk, as well as women. So women have some kind of unique factors that put them at a higher risk of stroke, including pregnancy, hormone replacement therapy or birth control, migraines potentially, and then obviously the atrial fibrillation that I spoke of. But some of these put women at an even greater increased risk of stroke than men. And we all know that as women, sometimes we put our healthcare after the care of some of the others that we take care of. So it's so important that we are making sure that those things are under control, that we know our numbers, that we're taking care of ourselves, and especially over this past year when we have all been at home a little bit more, maybe we haven't gone to our primary care physician. It's definitely time to make sure that you are just putting your health back, into priority. You're managing your stress, you're exercising, and doing all of the things that just put you at a greater opportunity to, not be impacted by a stroke, if that's the case.
Thank you so much. So Robin, we always talk about within ARH, we talk about the stroke care network. And I know a lot of our patients or our visitors, customers may not know about what the stroke care network is. So can you kind of explain that and then the importance of that affiliation to us?
So the Stroke Care Network actually is through the University of Kentucky Medical Center in Lexington. They are a comprehensive stroke care center. And what that means is, I guess about 8 years ago, ARH entered an agreement with them in their neurology program, and they offer to us 24 hours a day, 7 days a week, a comprehensive neurology consult, and then also an acceptance. So if we've determined that you've had a bleed and we're going to have to fly you out, they accept 100% of every one of our patients. They're never denied. So you will always have, care, and we're ready to send them there. Now, since we are doing our own and we're doing a lot of alt place and stuff, administration of the TPA at our facilities, we still have our neurologists here, but we can also reach out to them. So they work very closely with all the facilities. They provide us with teaching materials. They provide us with all the things that we need to help with the community outreach programs that we do yearly. And it's actually, just kind of like guaranteeing us until we can get to that point, we can do it ourselves, that no matter what, we will have somewhere we can send to you without delay.
Perfect. Very, very important for our patients. Thank you. And we've mentioned a few times on this call telestroke. So Justin, would you mind talking about what telestroke is and how that's employed at our facilities?
Sure. So telestroke it's probably been around for about the last 5 years. You know, ARH has had it for the last few months. It's a great tool. Across the country as a whole, there aren't enough neurologists to cover all the patients. So it's nice that you have expert consultation basically on a stick. So when you come to the hospital with stroke-like symptoms, within the first 4.5 hours, the ER staff is able to identify that, and they're able to call what's called a code stroke or a telestroke. So you'll get whisked off to CT. A lot of times while that's happening, we will hop on the cart. It's a little cart that they'll push in the room. It's got a camera on it and a screen. And so we'll pop up, we'll do an exam, we'll talk to you, work with the staff to see kind of what's going on. It's nice to be able to have expert care in people who are used to giving this clot busting medication and see, hundreds of strokes a month. So it's a great resource. It's a great tool to provide care to underprivileged, underserved areas that they wouldn't otherwise be able to get.
Perfect, thank you. So really the consensus that we've all talked about today is the importance of time. When we're talking about on a lot of our webinars covering cancers or reasons that you should have your preventative screenings, we always talk about early diagnosis as the key to survival. But this and stroke is really by the minute. So it's so important. And I know that is kind of what Dr. Corey was saying earlier is you've got to call the ER, or you have to go to the ER. You have to go as soon as possible and don't delay, even if you feel like, these symptoms are some of the things that you would usually brush off. And I thought of something else, Dr. Corey, that maybe you can speak to, but if someone were to wake up with these symptoms, but they don't really know when they started, so it's really hard for them to give you that point of symptom start. How do you deal with that in the ER?
Sure. So that's that's obviously not something that's in the patient's control from a time standpoint. I will say a lot of patients still wake up and they say, well, I might have just slept a little wrong. That's a common one. My arm's a little numb or I'm a little confused, and they go back to sleep. Unfortunately, that's a very common thing that we see, which we would again want to avoid. As soon as you wake up and you start to notice there's anything abnormal that could be neurological, like we talked about, all the symptoms, confusion, weakness, numbness, that's unusual for you. It's important that you, as soon as you notice it, to call. But typically, it becomes a bit of a sticky situation or kind of an interesting logic we use when you show up. And if you remember right, we talked about the use of the blood thinner and it being time sensitive. And your symptoms had to start within 4.5 hours definitively from when you showed up to get it. And so that becomes a problem. You can imagine if you went to sleep at 10 p.m. and you woke up at 6 a.m. or 7 a.m. and you came in and you had these symptoms when you woke up. We don't know for sure if the symptoms start within 4.5 hours in that circumstance. So usually there's some data coming out now that may liberalize the use of the blood thinner in that circumstance. But typically, if you went to bed more than 4.5 hours ago and you woke up with symptoms, I'm not going to use the blood thinner, the TPA we talked about. I would assume that it could have theoretically happened at 6 hours or 7 or 8 hours whenever you went to sleep. I have no way of knowing, so I don't want to risk that for the patient in the modern era. And so we would avoid the use of blood thinners, but we would go through the rest of the process normally. So we'd say, is it a bleeding stroke or a clotting stroke? It's a clotting stroke. We're not going to use the blood thinner, but we still get the CT scans to see if there's a big blockage. If there's a big blockage, clotting stroke, you probably go to UK in that circumstance still. Because we have a 24-hour window for a surgical procedure to pull clots out. We just don't have that window for the blood thinner that we use here. And if you don't have a clot, then we would, like Justin mentioned, we'd admit you like everybody else, and we would go through the normal process of workup and defining the stroke and trying to prevent the next one. So the big difference when you wake up with symptoms is you probably won't get the blood thinner depending on when you show up and when you went to sleep. But everything else will be the same. And I just want to emphasize again that just because you woke up with symptoms, it doesn't mean we recommend going back to sleep and see if they wear off when you wake back up. If you had a bad dream or you're gonna sleep it off, that's a commonly done thing, and it's very dangerous, and it causes you to miss a window for treatment potentially.
Thank you. And so also we've discussed aspirin. So Justin, you talked a little bit about aspirin, and then Dr. Corey talked a little bit about aspirin, how you use it. So just to abate any confusion, we use aspirin when we come into the hospital, but you should not use it beforehand. So you don't know, as a patient, what type of stroke that you've had. But once we do come into the hospital, then the doctors will decide, what type of stroke you had and whether aspirin is correct for you. So just, am I correct in that? Am I saying that wrong? Is that right?
You are correct, 100%.
Perfect. Just wanted to make sure there was no confusion. Okay, and then we do have a question that looks like in our Q&A. It is a clinical question, so please forgive me if I get this wrong or get tongue-tied. So let's see, in acute MIs, in some patients, there's a stunned myocardium or stunned heart and loss of heart function or lower ejection fraction. In some cases, that function will be restored down the road. In acute strokes, if neurons are lost, are there cases where some of the function will come back, or are the loss of neurons forever?
It's a great question. You about to take that one?
Go right ahead.
A question that I'd love to take only because I have this conversation about 20 times a day, every single day or more. So it's a great question. It's a very different circumstance. So the thing that's common about strokes and heart attacks is the risk factors that lead to the problem are very similar in general or the same. And it's a similar, in most circumstances, a blockage of an artery, which the risk factors lead to. That's the similarities. You're losing blood flow. As Justin said, you're clogging a pipe. One's to the heart and one is somewhere in the brain. So that's the similarities, but that's where a lot of those things end, because the heart is a muscle, just like, not the same type of muscle, but it is one of two types of muscle that could be analogous to a calf muscle. And muscle has, in general, a different ability to recover. And so muscle can regenerate to a higher degree, not that the heart can always recover, but just what happens when you lose blood flow to a muscle versus the brain is very different. Pathophysiologically, that's a big word there. And so what I would say about the brain that I have the conversation of daily is people want to know, hey, I'm obviously weak, or I've got speech deficits, or my family member does. What are the chances of improvement? And the brain and the spinal cord uniquely do not really have an ability to recover, right? And so everyone's familiar with kind of, Christopher Reeve's story and all sorts of things, spinal cord injuries and the devastating effects those can have, and other brain disorders. For a number of reasons, pathophysiologically, the brain and the spinal cord don't really have the ability to heal. The cells will not regenerate usually in most parts of the brain. But what does happen uniquely is that the cells that exist, of which there are billions with trillions of connections between the cells, unlike the heart, is that those connections called synapses, which is a connection between one neuron brain cell and another, they're very voluminous. So there are billions of neurons in the brain usually for most patients, and there are trillions of connections, synapses. And so I generally, when it comes to intelligence and functioning, like to make the analogy that it's quality over quantity. So in other words, you don't have to have every neuron in your brain functioning to still be a very, very high functioning person, or an above average intelligence person, or functioning very, very well. And so what I usually say is, the brain's injured, that's not going away, but it's very important to rehab in the first week or two afterward, especially, and just, I call it boot camp, right? So you got to go to rehab boot camp many times, or you got to really work yourself hard, because the brain will literally learn to create new connections from other areas that usually did other things in many circumstances, and it will overtake the disability. The brain can literally learn to almost circumvent the injured part and have other new connections from other areas take over that function. And it's such an interesting thing to talk about, because there are actually cases, sort of intriguing, that people become savants and just brilliant artists and all sorts of mathematicians and pianists, because the brain that usually did something else, which might be what's important for piano, will become so voluminous and so high powered to overcome the weakness, for instance, that now there's some sort of, gifted pianist or mathematician. So it's a very intriguing example that you have to learn it. To learn it, you have to really rehab at it. It's not going to fix itself like the heart will do. You have to really work at it, because it's literally the exact same process. Rehab from stroke is the same process as you learning to ride a bike or creating a new brain. It doesn't happen passively. It has to be something that the patient themselves engage in. But it's very possible. Just because the brain's injured doesn't mean it's not going to recover. You're not going to make full recovery, but it's not going to be a passive process. You got to learn a new trick.
Perfect. Love that analogy too. So the brain is an amazing thing. So we don't have any more questions on Q&A, and I don't think we have any more on, one just popped up as I said that on Q&A. Okay. You mentioned reviewing blood pressure and anticoagulants. Do you look at glucose levels as well? Dr. Corey, you want to take that?
Yes, absolutely. Glucose with any emergency is usually checked. That's kind of one of the first things, the ABCs, if you will, that EMS is trained on. And so EMS should be checking it on the spot usually, certainly before they get to us, as well as some other things like the vital signs. That is something that for seizures, strokes, heart attacks, everything in between, should be checked far before they reach us, or at the very least, we get that data before we start making decisions, because a low glucose is certainly one of the many causes of stroke-like symptoms or confusion and that type of stuff. So that is absolutely something to check.
Perfect. We have another that says, and Abby, please, if this is for you, please speak up. I'm not really sure if you would know this, but I saw recent data that shows nationally 87% of strokes are ischemic and 13% are hemorrhagic. Being in the stroke belt with the prevalence of hypertension, are those numbers different in the ARH catchment area? Do we see, more strokes that are ischemic? Is it the same way as it is nationally? And Dr. Corey, if you know the answer to that, please.
Yeah, so it really depends on kind of the data pool that you're looking at. And so the reporting mechanisms and areas and regional distributions. And so national data might not be as valuable or valid as kind of as they're referencing there, the local data. Personally, only having been here for 7 or 8 months, working in New York, Connecticut, down to Charlotte, in between, you do start to see sort of local or prevalence of interesting, whether it's genetic pools of variations of stroke and weird stuff that we don't see in certain parts of the country. We see a lot of, like, MS is decently prevalent here, it seems like, in the Northeast as well. But I would say in general, it's probably a very similar distribution. We may have a little bit more of the clotting pathology here, but if you remember, blood pressure being a big part of bleeding strokes, especially, but also risk factor clotting strokes, it really comes down to lifestyle. If it's a high blood pressure problem, you're probably going to have a lot of bleeding and a lot of clotting strokes, and that's what we really want to fix here, is prevent, not looking retrospectively and saying how much are we having of this or that. It's more saying the risk factors are the same. How do we get to patients, and how do we make sure that patients are taking care of themselves to where we never even have to look at that data to kind of make our judgment calls. And that's primary care driven, and making sure you show up so that if you have a stroke again, that we can treat you effectively and prevent another from happening. But it's a great question.
Perfect. Thank you. Now we have no questions in Q&A and chat. I think all of those have been answered. Thank you to our participants for asking so many questions. That is wonderful. We do have another, which is just a general statement, not a question, but just says, thank you so much for explaining what will happen so thoroughly. I have high blood pressure that has stuck around after pregnancy, never had it prior to pregnancy. And although I'm on blood pressure medicines, I've had a few close calls where my provider said that my BP was stroke level. So I think that Dr. Corey, you really spoke to that, and keeping up with your high blood pressure. It's not just whether you have had blood pressure, once, but making sure to check that all the time, right?
Absolutely.
So I think with that, we will come to the conclusion of our webinar. So thank you guys so much. I want to thank our panelists. We really appreciate you guys giving us your time. I know it's very important and you're very busy, and even more so your commitment to stroke here in Appalachia. So I really appreciate you all taking the time of being here with us. Hope to see you again in webinar series in the future. Before we wrap up, does anybody have any last thoughts they would like to give our participants who may watch this later on social media, or any of our participants? We have quite a few that are on right now. Just last thoughts ending our webinar.
I was just going to share some of the resources that I shared are available on the Stroke Association website. It's super easy to remember. It's www.stroke.org. And there is everything from prevention and how you can control your risk factors through what will happen if you have a stroke and you have to go to the hospital, rehabilitation, and then really life after stroke. There's a lot of resources for both patients and caregivers, because we know caring for a loved one that is recovering from a stroke also has unique challenges as well. So please feel free to visit the website. Anything that you see on there, there's a lot you can print. There's a lot of great infographics that are able to be shared as well.
Perfect, thank you. And I'll also say that I have a few of our references from today, and I will send those out to all of our registrants. We have the email addresses from all of our registrants from today, and I think I can send out, Abby, your AHA, your website and your resources, our ARH website, stroke support group, and all of those things. I'll put all of that in one email and send it out to all of our participants for today, as well as for the registration information for our next webinar. So again, thank you so much, panelists. Greatly appreciated. Unless anybody else has anything else, I will move forward. As a reminder, this is the third in 4 of our webinar series for stroke in May. The next webinar is going to be on Thursday, May 27th at noon. And if you attend 3 out of 4 of these webinars, you are registered to win a Feed Your Brain small kitchen appliance makeover. So tons of cool stuff. One of our biggest prizes that we've ever done for webinars. So I'm very excited about it. Please make sure that you are registered. And again, I'll send that out via email to all of our registrants from today and all of the people that came to this webinar. So you should have that for easy access. You can also find it on our Facebook page at Appalachian Regional Healthcare. So with that, I think we finish up our webinar. We hope to see you guys on the next one. Again, thank you to our panelists, greatly appreciated. And until the next time, we'll see you then. Stay safe out there.